working in KEM Hospital, Mumbai, and I was working with my colleague Dr. Kranti Kumar Rathod, and together we have devised a medical stent which will reduce obesity. And this design of the stent was approved by the US Patent Office, and we have been granted the US patent for this medical device to reduce weight in obese patients in April 2021. Once we have got the patent, we will further upscale it and see to it that whether this device is feasible, whether this device can be manufactured, whether this device will help us in minimally treating patients with morbid obesity. This is the only case that I know of a medical device which has been approved by US Patent Office till now amongst our interventional radiologists. There are many more in pipeline, and which we would subsequently see to it that we mentor each other and develop such devices in future.
Great.
On the device front, we have probably the only device in the world which was manufactured and designed by an Indian company and Indian doctors, and I was incidentally involved in the whole study project. This is a device which is what we call as bioresorbable stent, and that stent, the important criteria was that there was a drug on it also. So that helps to treat this peripheral vascular disease, and we were the first people in the world which we used it in humans, and that paper was accepted in Germany and in Paris, where we presented our data, and is now acceptable, and now it will be all on a manufacturing front, and within a year or so this will be available not only in India but all over the world. So credit goes to that the Indian brains and Indian minds have worked on it and have been successful in treating these patients.
Okay, great.
Bioresorbable drug-coated stent.
Okay, that is the name of the device?
So the name of the device is Credence BTK.
Okay, great. One more question to you, Doctor. You mentioned that Tata is amongst the world's best training center. Now, as Indians, we are proud of this, and it's a matter of, I think, applause for everybody. But is there any certified body or any such data which says that Tata is the best training institute in the world for something like this?
Yes, I think Suresh would be the best person to answer this. He is heading that Tata Institute and is the head of radiology also.
So regarding especially the training in interventional radiology, Tata Hospital is the first institute which has got a 3-year Medical Council of India certified DM in interventional radiology course. So we started around 4 years back. We started with 2 seats in DM in intervention radiology, and recently we got approval from the National Medical Council, which is now with MCI has been replaced by National Medical Council. It has approved 4 seats of DM in intervention radiology, which is the first institute in India for training the students after MD in interventional radiology. Similarly, Tata Hospital also has 2-year dedicated fellowship course in interventional radiology, which has been affiliated to Homi Bhabha National University, which is a deemed university under which Department of Atomic Energy runs various teaching courses. So under that university we have a 2-year HBNI Intervention Radiology Fellowship course. And we also have 1-year certificate course of Tata Memorial Center itself in intervention radiology. So at any time there are 10 to 12 fellows who are getting trained in intervention radiology in Tata Memorial Hospital, and that is probably one of the highest number of students which are getting trained in intervention radiology, and that is why I am sure Dr. Hemant Deshmukh has said that it is one of the leading institutes, and it also has collaboration with international institutes like King's Medical College, London, as well as Miami Cancer Center in Florida. So we have affiliations with such international institutes as well. So one of the best training is given in intervention radiology in Tata Memorial Hospital.
Great, fantastic. And in terms, sorry, you want to add?
To add to sir's thing, if you take interventional radiologists in entire India, 80% of them are trained in Bombay and from KM and Tata.
Wow, great. In terms of industry impact, do we have any study which gives the number of cases that have been treated through the process of interventional radiology in this country? And what is the kind of impact it has in terms of on the industry in terms of numbers and size, and at what percentage is it growing every year annually? How many people are adopting for this kind of treatment? Is there any proper study on this? And if so, what do these studies reveal?
So this is what we call as registry data. Rather than the industry, it is the society which handles this. And we do have our registry data collection every year. And as we have understood it over the years, there is an average of 8 to 10% increment in number every year. And today I would say that, as somebody mentioned, that we have more than 1,000, about 1,100 members in our society. There is an average number of procedures that are being performed in interventional radiology is more than 50,000 per year in India. So the numbers are ever growing, and I'm sure the jump will be now much more, and that's where the media will play a role. We want to reach out to the people and tell them there is this branch of medicine which can be taken and can be helping in the treatment of a lot of patients. So the growth is very rapid. Lot of new technologies, lot of new techniques are being developed, and the growth is very rapid now.
Great. Medical tourism is booming in India. So as far as medical tourism goes, do we have people coming to India to take the service of interventional radiologists?
Yes. It's a great question. So as we have already discussed, interventional radiology is available everywhere. But the cost and the waiting list when compared to UK and US, in India it is easily available at a better price, and it's affordable, and they can reach India easily. So all the major hospitals such as the private entities like Apollo and all these other hospitals, they are offering medical tourism and interventional radiology as a specialty to all the foreign patients. As a doctor, I have already treated many of these Saudi patients, Tanzanians, Nigerians. All these patients come down for the treatments. So it is, yes, very much available for medical tourism.
Cost is where healthcare sometimes becomes health scare. And in fact, my friend was just prompting me from behind and requesting me to ask this question to the doctors. You did mention cost, and you did mention the benefits of shorter stay and keyhole surgery or pinhole surgery, minimally invasive surgery. All those things well understand and well appreciated. But can you give us an actual perspective of cost? How does it compare with the other alternative methods of treatment?
Okay, so I will also like to answer your previous question,
yes,
especially about the medical tourism. So in fact, we do not like the term tourism when it comes to medical science, because it is all giving care and not earning out of
Pleasure.
it, as the tourism word goes to. So apart from the corporate hospitals where the rich patients from Saudi and other Gulf countries can come and have treatment in India, but especially for cancer care, when we talk, Tata Hospital, we get patients from all over countries in this part of the world. Like we get patients right from Afghanistan, from Nepal, Sri Lanka, Bangladesh, and they may not be very affording kinds, but they get the best treatment, best treatment at affordable cost. So that kind of medical tourism we practice. At the same time, when you talked about the cost effectiveness, as we call about this particular treatment, yes, it is minimally invasive, so it is daycare procedure. Patient do not waste many hospital days, so he doesn't lose his income or working days, as compared to the other traditional ways of treatment like surgery or chemotherapy and other modalities of therapy. The patient has to undergo a long hospital stay because he takes time to recover. So he and his family, they lose their income. At the same time, because they are morbid procedures, there might be more complications. So again the cost of other auxiliary treatment increase, that again adds to this. And as against that, with shorter stay there is significant saving for the patient as well as from the out of the pocket expenditure for the family. So all these, if we consider together, these minimally invasive treatments, which most of them are daycare, is a big saving for the patient, and that is how they are cost effective as against other modalities of treatment.
I think the device cost must be higher, but the gain is that these patients get back to work as early. The family is back into their business or work as early. So therefore, the cost, actually if you calculate every which way, may be equal or much less than the corresponding surgical procedure. So that is what is a major advantage. So these devices have played the trick and helped treat these patients more effectively.
Just to add to that, fortunately Government of India and all the state governments have incorporated now practically all the intervention radiology treatments in government health schemes. So the Pradhan Mantri Arogya Yojana, or in Maharashtra Mahatma Jyotiba Phule scheme, all of these things, Ayushman Bharat scheme, are covering up all the intervention radiology treatments to that extent that stents are also covered free for these patients under this scheme. So that way, fortunately, intervention radiology is able to reach the last mile or the poorest of the poor in the country.
To add to it, again, Mahatma Jyotiba Phule covers up to 1.5 lakhs, and many procedures are less than 1.5 lakhs. So that keeps you.
Yeah, so that is what we wanted, the perspective on the cost.
Yeah.
So now you come up with a concrete figure. So when you mention 1.5, sorry to interrupt, just one more line. What would be a comparative figure on the other end for another alternative treatment?
It is difficult to generalize. Again, the way it has been told. One patient walks out in a day or two.
Okay.
Versus a patient who hangs around in a hospital for 8 to 10 days with 2 or 3 relatives. So you don't calculate the cost of 2 or 3 relatives who are also spending along with the patient, and they are out of work for those many days. So if you really compare, you can't just compare one treatment cost to other treatment cost. You have to calculate so many different things.
Total economic cost.
So economically it becomes more viable when a patient walks in and he's back on work as soon as possible.
There's one more important factor you have to consider. There are many treatments interventional radiology offers where there are no alternatives.
Yeah, life
saving. If you talk about liver cancer, for example, really speaking, for most patients, there is no alternative to interventional oncology. For stroke, there is no alternative to stroke thrombectomy. It's not as if you can operate and remove it. You can't. So there are many treatments where we are unique, and yes, there are many treatments where we are competing. But if you talk, for example, about a simple thing like prostatic artery embolization, yes, you may feel that the cost of the procedure is higher than that of surgery. But then you're not calculating one. The patient will spend almost 5 to 7 days in hospital. They never tell you that each day in the hospital bed is going to cost you between 20 to 30,000 rupees at least. Whereas ours is a daycare procedure. It may look like the sum is higher, but actually you'll go back in the same day and that's all it will cost. Whereas a lot of surgical procedures or other procedures have a lot of hidden costs. For most of us, it's always been something we hear all the time. The cost is high, the cost is high. But you have to look at the global cost, not just cost of procedure, but cost of treatment, the whole thing. And that's where we really make up. And lastly, yes, a lot of our devices are important, and that's why the cost is high, which is where we are really working hard with industry. And as Dr. Someshwar mentioned and as Suyash mentioned, we are working hard in a lot of things. We've already got Indian alternatives which are about 1/5 to 1/10 the cost of what is imported. Once that becomes more widespread, once the knowledge is widespread, patients are using it, industry will find it easier to support the investment required to make these things in India. Otherwise, it's not worth it, right?
Absolutely.
As scale increases, everything will become cheaper, and that's why we want more patients to benefit from this. Just give a global perspective of this.
So one more thing I would like to add. So I mean, like, cost is one aspect, but lot of our procedures are actually life saving. So surgery, etc., if it is available, it become more invasive and it take quite long time. So sometime, like, some patient is having internal bleeding because of any region. surgery is an option, but most of the time the bleeding source become very difficult to control by surgery. In those cases, our procedure comes very handy in terms of life.
Only choice.
Only choice.
And surgery cannot be done in those cases many a times because it's very difficult to find a small leak. Here we can be so precise that a small leak can not only be picked up but can also be treated.
Sir, in case of an emergency, see a patient was taken to the hospital, see normally by their neighbors or their family people. There immediately the patient will be sent for identification to a radiologist. What the cause is? The main issue or the irony is the public has no role there. The medical board will decide what to do. As you have mentioned earlier, see there is a mechanism within 24 hours he can, through a balloon surgery, he can be sent back within 24 hours. But did the hospital allow that?
So this is what actually we want to...
In that case, how can we intervene the decision of the medical board? Say, sir, I want to do this.
A very big question.
Yeah, public awareness.
So this is why we are talking to you.
So this is
The patient has to see, unfortunately or fortunately, the fact is the power equation in healthcare is such that if I tell you this is the treatment and you are in an emergency, you will not know what else can be offered. But supposing you are aware that if the patient is having stroke, there is option of stroke thrombectomy which can save life, save function of limbs, then you may say, okay, if your hospital doesn't have it, I need to go where it's available. But if you're not aware, they don't have it, they don't tell you what you do, which is why we want you to make the people aware of what options are there, firstly. Secondly, yes, but it is a legal requirement that the patient should be informed. It's an ethical requirement for us. When I offer the patient angioplasty, I also tell him the surgery is an option. These are the advantages of surgery. These are the disadvantages of surgery. These are the advantages of angioplasty. These are the disadvantages of angioplasty. So in a given case, like Suyash said, decisions are not taken on the basis that this is what I do, so I only do this. Decisions are taken based on what is best for the patient. And this is what you are pointing out, that the patient is sometimes not getting a choice. Right? So how do we improve that situation? Both doctors and patients have to become better informed. Like when you give a vote, the better informed you are, the better you vote, and the more important you think your vote is. Similarly, if you improve the information available to people, they'll make better choices, they'll ask better questions, they'll demand more from the hospitals, from the healthcare system, which is why we are, talking to you. So
that's why we basically request you to propagate this knowledge of interventional radiology to most of the people, because they're not aware about our branch.
It's pure awareness.
Again, that's why I said twice, ignorance is not an excuse. If people don't know, they won't get the proper treatment, they won't ask for the proper treatment. So we have to convey it, and there comes a role of a media. So you can convey it to lot of population. This entire country requires this knowledge to be propagated from your side.
So I would like to add here, it is a very pertinent question that you asked.
Yes.
Because patient doesn't know what is the right treatment and the hospital takes the decision, and whosoever is present, whichever specialty takes the decision, and the patient gets treatment accordingly. So the need of the hour is to have teams of doctors who will work in groups, like in KM hospital, other municipal corporation hospital, or in most of the government hospitals. There are stroke teams where neurologist, a neurosurgeon, and intervention radiologist together, they work and they come to a proper decision where which particular treatment is right for that particular patient. So as Intervention Radiology Society, we are not saying that we can treat everything, that we are gods. It's not that. We are a part of the whole system, and we insist that a proper group of doctors should take the right decision. Similarly, as Dr. Nitin said, in Tata Hospital and all cancer hospitals, the decisions are taken by a tumor board. It is not only an intervention radiologist or a radiologist or a surgeon or a medical oncologist. They come together and decide the right treatment, and that is the right option, that is the right approach towards imparting proper care to the patient. So what we call it as evidence-based medicine, that is practiced. Unfortunately, in many cases, it is the economy-based medicine that is given preference to, but we insist as a society that let interventional radiology be part of these treating groups so that patient gets the best option for the treatment.
Yes.
सो इसके बारे में मैं एक सिंपल से बता देना चाहता हूँ कि 2003 में जब मैं ड्राइविंग लाइसेंस बनाने गया तो मुझे पता लगा कि ड्राइविंग लाइसेंस बनता ही ऐसे, बाहर एक एजेंट बैठा है, उसके पास गए, उसने मुझे बताया तरीका के अंदर जाइए। इससे बिकॉज ऑफ मीडिया इन अनदर 10 years 2013 तक आते आते मुझे पता लगा बाय मीडिया पीपल, बिकॉज यू ओनली पीपल अवेयर एस कि आपको डायरेक्ट जाना होता है, आरटीओ के पास जाएँ, वो आपका लाइसेंस बनाएगा। यू डोंट हैव टू गो टू द एन एजेंट, यू डोंट हैव टू गो टू द चैनल। सो मैं उनके पास गया। नेक्स्ट टाइम जब मैं गया तो थोड़ा सा मुझे और कॉम्प्लेक्स लगा, लेकिन एजेंट की ज़रूरत नहीं पड़ी। दिस टाइम बिकॉज ऑफ मीडिया, आप लोगों ने इतना बताया, आरटीओ से हमें पता लगा, बिकॉज ऑफ मीडिया प्रेजेंस, बिकॉज ऑफ सोशल मीडिया, बिकॉज ऑफ न्यूज़पेपर, मैं डायरेक्टली गया, मैंने एक फॉर्म भरा, अगले दिन लाइसेंस मेरा घर पे बन के आ गया। बिकॉज ऑफ मीडिया प्रेजेंस मुझे ये पता लगा कि मुझे और किसी के पास जाने की ज़रूरत नहीं है, लाइसेंस बनवाने के लिए मुझे आरटीओ के पास जाना है, जो कि मुझे 2003 या 2013 में नहीं पता था। सो दैट्स वाई दिस अवेयरनेस प्रोग्राम इज़ क्रिएटेड कि इतनी सारी जो बीमारी हमने बताई हैं, ये एटलीस्ट आम जनता को ये पता हो कि आईआर क्या है, इंटरवेंशन रेडियोलॉजिस्ट कौन है, ताकि वो पूछ सकें जाके कि ये मेरे को पैर की बीमारी है, क्या आपके हॉस्पिटल में इंटरवेंशन रेडियोलॉजिस्ट है जिसको मैं दिखा सकता हूँ। उसको एक सिंपल क्वेश्चन पूछना है, क्या आपके यहाँ पे इंटरवेंशन रेडियोलॉजिस्ट है जिसका मैं अपॉइंटमेंट ले सकता हूँ।
Is there any provision for patients to go to a hospital and ask them?
Yes.
I want to meet a
Yes.
radiologist.
Yes.
They allow that.
We have
very much.
So fortunately, all
Then
hospitals.
see, usually they may tell us, see why we are sitting here. We will decide. If the medical board is there, we will decide what to do. Then another thing, see if you are giving, say applying a stent, Indian stent costs 10,000 rupees. Then foreign stent costs 55,000 or 1 lakh rupees. Then they will tell you, see, in Indian stent it is low cost, but quality may be the same. But doctors always prefer to use the foreign thing because there may be so many other things, including commission or something. There also, see, patient will be suffered.
So that is not the right platform to tell you about this.
So,
Can we clear this?
So sir, can I clarify one thing? Fortunately, intervention radiologists across all metros or tier 2, tier 3 cities are available in most hospitals across the country. Though we may be small in number, but we are available everywhere. It is your right when you reach the hospital and you say, I have chest pain and I need to see a cardiologist. It is your right to ask for an intervention radiologist. If you create awareness through media, surely intervention radiologists are now not just operating, we are available for consultations also. So we are available for you to come across the table and discuss on consultations, how you consult your general practitioner. So we are available across the country. You have to ask for that.
So the last question, sorry, you wanted to add?
To clear your doubt, sir, I have done fellowship in 2006 in KEM. So whenever there is a patient of aneurysm or anybody who comes into KEM, he has been given an option of neurosurgeon, interventional radiologist, always. So we used to discuss with the patient that these are the options and these are the benefits of these things. Coming from there, I am now practicing in Apollo Hospital, Hyderabad. Even today, all the patients are being given the options. Which doctor do you prefer? These are all options available to you. So the doctor never decides for the patient. And once the patient has the knowledge that I want intervention radiologist, they cannot force you to go for surgery or anything. So it is always knowledge, awareness and knowledge.
Done. Thank you. So we'll ask one. Sorry, this mic. Can you hear me? Yeah.
Yes.
So one last question, then we'll wind up the question answer session. Abroad, there are many countries where there is a system where the success rate and the failure rate of individual doctors and maybe even institutions are displayed for public consumption so that they can make an informed choice. Our last question was about awareness and informed choices. Yeah? Is there any such system in play as far as your specialty goes? And is there any such system that will come in play in the future for medical science as a whole and more so for highly specialized fields like yours?
This is the difference between developing and developed country.
Absolutely.
That's why we still call ourselves as a developing country, right? We are yet to cross that big hurdle of becoming a developed country. So I believe with the growing number of doctors over here, we will be reduced by lots of pressure of work, because government is planning that every district should have one medical college, right? So lots and lots of doctors will come. So we will get more time to scrutinize our work. Once we get more time to scrutinize, because right now we are overloaded with work. And with lots and lots of time to scrutinize our work, I believe we will soon become a developed country in terms of health also. So this is a process. This is not going to take maybe in next 2 or 3 years it will happen. This will take a decade also. 10-15 साल 20 साल लग सकते हैं इसमें, and I believe we will soon become a developed country in terms of health also.
There has to be some data collection, data analysis, and then the outcomes. So this is what we need to do. All of us are aware, and as a society we are making an effort in that direction, that all of us contribute and decide. Now this meeting of complications is a very important part in our teaching program, that if I have done a complication, I want to teach my juniors that you should not repeat it. The whole idea is to improve the quality and improve the patient care, and that is what the whole purpose of this meeting. So these are the steps, and as time goes, data collection, data analysis and outcomes will be analyzed and brought up in front of people, that what we are doing, how much is good and how much is bad.
So Vivek, to answer your question, as you rightly said, we need to have some figures for the general patient or public to assess which particular treatment to opt for on that basis. So as rightly Dr. Vimal has said, as a society, we are in the process of establishing registries for various procedures that we do. So with these registries, with individual hospital as well as national registry, we will come out with the results of the outcome of our procedures. Vis-a-vis, we can compare it with other modalities of therapy, so patient can decide which one is better. And the best way to do it is to analyze it and publish it, and that is again one initiative that the society has taken, to have a journal which we call as Journal of Clinical Interventional Radiology, in which we will publish these results so that it goes to the scientific community to know that the advantages of these treatments. Also, as a society, we will be coming out with some consensus guidelines and quality improvement guidelines. As Dr. Vimal has said about this meeting, we'll come out with the complications, how to prevent them, as well as what can be the thresholds of complication, so that below that threshold we should remain, so that we can give safe treatment to the patients. So all this data will come out over a period of time, and that is how patients will get this information.